Good evening, colleagues. My name is Brian Morales from the U.S. Department of State, and you are joining the December session of the Global Coalition to Address Synthetic Drug Threats, Sub-Working Group 3.2, Engaging People with Substance Use and Substance Use Disorders. This is the West Group session. We had the East Group session meeting last week on December 14th. I have a few administrative announcements to get ourselves started this morning. First, I want to speak about civil society engagement. As some of you may know, in July 2023, when the ministerial meeting launched this global coalition, a declaration was also agreed on related to accelerating and strengthening the global responses to synthetic drugs. At that session, participating governments expressed their commitment to take into account input from civil society and coalition objectives. Now, these meetings that we've been having every month, we've decided by consensus that they would be closed to government and international organization staff, representatives. So we have developed this 5-part plan to engage civil society, and that will be posted in the coming weeks on the Global Coalition website, which you see there on the hyperlink. So in short, the first opportunity for engagement will be the formation of national dialogues with coalition governments, beginning in the month of January. We encourage your governments to do this as well. The United States will lead by example. We will have our own national dialogue with civil society organizations on the 27th of January to hear their voices, to have them reflect on the coalition themes. And so that is an opportunity where we encourage you to provide a readout information from that session so that we can put that on our coalition website. Additionally, we will be supporting the Vienna NGO Committee, which will be hosting a global civil society forum related to the coalition, also at the end of January, beginning of February. Third, we will be looking for contributions from civil society organizations, content that we can post on our website, that may be video recordings or maybe documents. Fourth, we'll be looking for concrete policy and programmatic ideas, recommendations from the civil society organizations that can also be shared on the coalition website between the months of January to April. And finally, from April to July, we will be inviting civil society organizations to share their achievements, and we will be also posting those on the coalition website. Finally, at the discretion of co-chairs, we will also consider some sessions that we may have with civil society representatives to engage directly with countries in one of these type Zoom meetings. So we'll consider, based on the direction, the discretion of the co-chairs in each of the sub-working groups, whether we can look at these opportunities beginning in the month of April and onward. Finally, this is my last slide. I want to share with you all that we have a website for the Global Coalition. It's globalcoalition.us. We encourage you to visit the site. And I want to point out one specific section, which is where the sub-working groups are listed. You will notice that we have upcoming agendas there. So please check out that space so you could see the latest agenda as we sort of maintain that updated live schedule of what we will be posting in the coming months. And we will also have on there past recordings. So if you've missed any of the sessions and would like to see some of those videos, you will find both East and West Group sessions there. And the last thing is to also invite you all to share your own recordings, your own videos or documents that you would like to share with other coalition members. We are happy to also post those under each of these sub-working group themes so that we can share and expand that experience with other colleagues. So those are the announcements I have. I'm going to stop sharing my screen. And now I'm going to turn it over to our co-chairs for today, Dr. Nicholas Priest and Dr. Yuri Kutipe. Over to you, colleagues. Thank you so much.
Bonjour
Muchas
Brian,
gracias,
bonjour
buenos días.
Yuri, bonjour à tous.
Sí,
Je suis donc Nicolas.
Hello, everyone. I hear several people speaking.
Yes, with my colleague from France, we will co-chair this.
French channel. The French speaker needs to be on the French channel, please.
Bien, gracias.
Yes, thank you. First of all, we will there will be a presentation regarding the low intensity treatments. This presentation will be in charge of Anja, which is the program officer from UNODC, and also Dr. Dzmitry Krupchanka, which is the medical officer from WHO. This presentation is a video, and we will ask you to please, if you can share the video with us. Thank you.
Good evening, good morning, good day, everyone, to this session of the Global Synthetics Coalition. And we're here from UNODC and the World Health Organization to speak for a moment about our new products around mainstreaming treatment of drug use disorders into health care, and specifically the implementation of the WHO UNODC international standards for the treatment of drug use disorder and how their dissemination can help achieve this goal. And we will be presenting to you together. I'm here with my colleague, Dr. Dzmitry Krupchanka, who's medical officer with the Alcohol, Drugs and Addictive Behaviors Unit of WHO. And as you know, I'm Anja Busse with the Prevention, Treatment, Rehabilitation section of UNODC. As you might be aware of, the international standards for the treatment of drug use disorders are developed on the basis of a number of technical documents of UNODC and WHO. And since they have been launched in 2020, they really have become an internationally recognized tool and a common reference point for a lot of countries. They have at least been backed up by two resolutions of the Commission on Narcotic Drugs, but also by the General Assembly.
So greetings, colleagues from Geneva, and I would like to continue what Anja said. The international standards is kind of a very well acknowledged now a reference tool for a variety of topics related to treatment of drug use disorder. But also it's important not to forget that there are other tools which contributed to the development of standards, that they still can be used for more specific activities like WHO assist screen and brief intervention package, you can see here on the right, or guidelines on treatment opioid dependence, guidelines on overdose management. Then we have MHGAP guidelines for treatment of comorbid mental health conditions. We have guidelines and documents for specific population and groups. But at some point, it was we were informed by countries and colleagues that we need to develop a once document that brings everything together. And we started this work a long time ago, was almost 10 years ago. In 2016, we launched the first version of the International Standard for Treatment of Drug Use Disorders. And then it was field tested in 9 countries, where we collected information on barriers, opportunities, but also on what are the potential revisions that could make the document stronger. After this field testing, we revised this document and launched a second edition in 2020. And as indicated on this slide, you see we make sure that all the tools that I mentioned and others, they are properly reflected in this document. They acknowledged and they build in the areas which require attention. But then what we learned during field testing is that just this document is amazing tool, but the question is how to make it work in countries, how to implement it. And that's why to serve this purpose, to make the implementation smoother, easier, and clearer, we have been working on the implementation toolkit, and very soon we will launch it. So it's a very advanced stage now. And actually what we tried also to do, we tried to find any other potential sources that can help implementation, such as WHO health system framework, such as WHO core competencies frameworks, rapid assessment guide for emergency settings, quality assurance tools. You've probably heard a lot about them. I think it's also a very important and strong tool that can be used for implementation. Also WHO tools for mapping service capacity, etc., etc. So we try to accommodate them into one implementation toolkit, and the hope that in coming years we'll be doing piloting in countries and then implementation and scaling up. So this is a very quick snapshot on the content of this implementation tool. It basically, this structure mirrors a bit the structure of the standard. So it has a system setting and services level, then treatment modalities and intervention level, and also population with special needs. And it kind of highlights 4 main stages for the implementation, which are assessment or landscape analysis, action planning, implementation, and then monitoring and evaluation. And then for system, for service, and for intervention level, we have different kind of sub tools or different frameworks that would help the implementation. So idea that the country can decide if they want to do the full package implementation or if they want just to focus on settings or intervention or system levels. So it's kind of a versatile tool, but of course we need to work more to adapt it and to really hear from countries after piloting how this needs to be further changed or finalized.
So, and with this, if you're interested in working further on the implementation of the international standards for the treatment of drug use disorders and work with us with this new dissemination toolkit and see how we can support your country in making or reviewing how much you're already in line with the international standards, or kind of want to develop further to develop your quality drug treatment and rehabilitation services in line with the standards, we would of course also be happy to work with you and UNODC WHO. We have for over a decade a very successful interagency program, the UNODC WHO Global Program on Drug Dependence Treatment and Care, that has worked since 2009 to support development of comprehensive, integrated health-based approaches to drug policies with the aim to reduce the demand for illicit substances, including synthetic substances, of course, reduce suffering and decrease drug-related harm, not only for individuals, but also for their families, communities, and in the end, kind of the societies as a whole. So this would also be our vehicle to implement a number of specific projects or initiatives in countries, again, including the dissemination toolkit of the standards. And we would be very open for partnerships and would love to hear from you how we can coordinate and support you in your efforts to ensure quality, accessible, and evidence-based drug dependence treatment and care. Thank you so much for that. And maybe last not least, of course, we would like to thank the donors of the UNODC WHO program on drug dependence and treatment and care, who have given us their trust for all those years since 2009. Thank you so much, and over to the chairs again.
Muchas gracias, Anja.
Thank you so very much, Anja. Thank you, Dr. Krupchanka, for their presentation. It's so clear and concise, and it's obvious that it's a challenge for all our countries to be able to reach and have access to the international standard for treatment and evidence-based standards. And as an example for this, or as a process, let's say, of implementing of standards, is a testimony by Dr. Luiz Gonzales Carey, who is the coordinator of comprehensive health in the National Drug Committee. Uruguay is one of the countries in Latin America that has better developed the treatments at different levels, and obviously always following the international standards. So I will show you now the video sent by Dr. Luiz Gonzales. The video, please. The NADRO which is the National Integrated Health. We have the national system, and we also have the mental health law, which is the Decree 274 from 2013, which establishes the standards. This national comprehensive health, everybody in the country is covered. We have the right to access to this system. And the issue of drug, there are some compulsory services offered by the government. This system has different benefits. It has a permanent in-person or telephone support, a multidisciplinary outpatient care, polyclinics, hospitalization due to intoxication, group care for family members or emotional references of users with problematic use of cocaine and cocaine, individual and base and free base. And this is covered by the new law. And also we have the hospitalization of people with problematic use, sometimes for 30 days. If you are under 18, there is no limit in the amount of days that you can stay in the hospital. All these services are basic, that all of us in our country have access to. Regarding these benefits, Uruguay developed what we call the RENADRO, and basically this system has different projects, programs that complement the basic systems and benefits offered by the government. This national drug network complements what, as I said, the benefit systems of other services, and this system is administered by a trust. And therefore we receive funds from any organization, and this allows us to have a very flexible system. And sometimes if the public service cannot offer these services, RENADRO will be able to offer them. Something important in the model that we have is that we do not buy what we call slots in third parties. So what we do is we put out bids so the civil organizations can implement them. So these programs are designed by the RENADRO, and what we do is we work with these NGOs to improve these projects based on the services that were offered before. So this trust works like a common fund. This and anybody can put their direct finances or human resources or material resources. This network basically allows the government to offer all the services, and what cannot be covered by one state or one province, you can use the funds from the trust to cover that. And this is like a comprehensive system. So what we have is we have people that are part of the Ministry of Health. We have from a representative from Social Development Program, and also we have the private sector. So as we said, some of the services are hired directly by RENADRO. So these are the different modalities and the different programs that we have. We have different programs that offer inpatient, outpatient system, inpatient programs. We have mobile care unit, and these systems are not only in Montevideo but also outside Montevideo. We also have specialized systems, and there are other programs that we call aleros, and basically they work with the community. And we have the mobile care unit that basically work with people, with homeless people in Montevideo, and of course there is no community there, so these systems help them. We also have what we call the achique, which is the daytime low threshold services. For example, they can use the bathroom. This is a service, a very basic service for these people. But we also offer them some skills for social inclusion. And finally, we have something called CHANES, which is what we call inpatient comorbidity, and
Esta presentación a cargo de
Well, this presentation by Dr. Luiz Gonzales Kellis at the National Drug Council in Uruguay illustrated how countries are systematically developing the services that are needed to treat the issue at different levels. After the following, our next presentation, we will have an open discussion of the topics we have addressed. But before, we're going to have a presentation on treatment due to stimulant use. And we're going to hear from Dr. Sanga from University of Colombia, which is a recorded presentation as well. Let's go ahead, please.
It's actually a live presentation.
Ok. Buenos días, doctora Bizang.
Okay, good morning, Dr. Bisaga.
Hi. So I'm gonna have this presentation together with my colleague. I'm speaking to you from New York City, and my colleague Anja Busse is on a mission in Kenya. And we would like briefly tell you about the treatment framework for individuals with stimulant use disorders. As you know, stimulant use has been rapidly expanding. This is most commonly used of the new psychoactive substances, and many countries feel at loss as to what we can offer to those individuals. The problem is that current treatment strategies are not very appealing. They're not based on scientific evidence and have limited effectiveness. And because of this, it's very difficult to attract people into treatment, and many of them are not receiving services. So in response to this need and requests from member states, we assemble about 40 experts from 25 countries that had sat together for several days and developed this document, which summarizes scientific evidence on treatment of individuals with stimulant use disorder, and made a call to action for member states to consider expanding and implementing those services in their specific countries. And if we think about how the healthcare system can respond to the problematic use of stimulants, it includes several areas of interventions. It includes preventing harms, reducing harms to people who currently use and are not in treatment, primarily focusing on developing treatment strategies, and also supporting recovery for those people that have recovered and would like to continue live in the communities. There is variety of prevention of harms that are, those individuals are at high risk, and we can screen them and treat them for commonly occurring and easy to treat infectious diseases. There is also, for individuals who use substances, there is a lot of efforts that we can devote, provide basic needs like a food, shelter, and hygienic services, educate them about medical and psychiatric effects, on safer use of substances, how to prevent overdose, and how to also provide services to people who inject drugs. But the core of the intervention is actually a treatment that would bring patients into care. Traditionally, those individuals are very ambivalent about stopping use. They're impulsive. They often have cognitive impairment. And I think priority is for us to attract them into care. And we can do that through using non-judgmental, non-stigmatizing, and patient-centered approach, offering a supportive, welcoming, and accepting environment. We make those services easily accessible to everybody, regardless of the age, gender, economic status, especially focusing on vulnerable populations such as youth or pregnant individuals. At the core of this, also, we have to think about bringing down the stigma about being in treatment and being in recovery. And to do that, I think it's very important to involve peers or individuals with lived experience or those in recovery who can help us design those services. When you think about treating stimulant use consequences and stimulant use disorder, we have several medical interventions, right? We have interventions that can help treat acute effects of stimulant use, such as overdose, intoxication, withdrawal symptoms, psychosis, suicidal ideations. Many people who use stimulants chronically have psychiatric syndromes that can be treated, such as depression, anxiety, sleep disorders, problems with violence or chronic psychosis. We can treat and diagnose and treat frequently co-occurring psychiatric conditions such as depression, ADHD, and other substance use disorders. Many of them have cardiac or cerebrovascular toxicities that can be also treated, as well as neurological syndromes, primarily cognitive impairment, that also will benefit from treatment. So we can do a lot there. But for individuals who would like to stop and are unable to stop using drugs, we have specific treatment interventions. So those treatment interventions are summarized in this document that I encourage you to review. This year, 2 professional organizations in the US also issued an updated guide for management of stimulant use disorder, and the MH-GAP program have also issued just last month an updated review of the psychosocial and pharmacological intervention. So a lot of this is already available and could be incorporated into building a treatment program. So as far as the medication that can help individuals decrease use and for those that are abstinent to prevent relapse, there is no medication that is approved anywhere. However, there is quite a strong evidence for effectiveness of several medications, including naltrexone, bupropion, or actually a combination of naltrexone and bupropion that has been recently found to be very effective. Topiramate and mirtazapine are 2 other medications that has been found to be effective. And one of the very exciting options is the use of the prescription psychostimulant medication. So this is the similar treatment paradigm that has been found very effective for opioid use disorder, is the medication that can be administered in a supervised setting that will help individuals decrease craving and stop use. And those medications can be effectiveness of them can be enhanced by using extended release preparation so that patients don't have to take them every day, but combining with behavioral interventions to, for example, improve adherence with the medications or adherence with the program, and also by matching the right medication to specific patient needs, so patient medication matching. There are also behavioral interventions that have been consistently found to be very effective. The most effective one is the contingency management, which is the program that administers positive reinforcements for the desired behaviors they would like to strengthen. The community reinforcement approach is the behavioral intervention that can work on changing incentives to encourage abstinence. Other interventions are maybe less effective, but can certainly be very, work in complement, like a cognitive behavioral therapy or motivational interviewing. And there are also exciting novel approaches. For example, the effects of physical exercise, mindfulness meditation, or the phone-based app-based therapies. There is a lot of, I think, excitement in the last few years about the effectiveness. And often those treat interventions can be used in combination to design a program that will be tailored to a specific population. And finally, of course, all those patients have to be supported in recovery long-term after treatment is finished. And we can do that by incorporating peers into the treatment team. So again, just to summarize, it's very important to make treatment very attractive for patients, to provide broad range of services, not only medication and the psychosocial interventions, but also outreach, harm reduction services, medical prophylaxis, and the recovery services. It's important that we collect evidence to test the health and economic benefits of this model. And in the United States, due to increasing impact of stimulants on public health, the rapid increase in overdose deaths specific due to stimulants, there is a lot of renewed interest in developing medication treatment, and it's a priority now for US federal agencies. So let me give it over now to Anja, who can tell you how the member states can be involved in this effort.
Wonderful. Thank you so much, Adam, and hope you can hear me well, joining you from Kenya, as said. So what we are thinking that there is really a momentum at the moment, and that the international community should take this work further. And what we are suggesting is a global initiative, which we will call Scale Up, Scalable Interventions for Treatment and Care of Stimulant Use Disorders. We have soft launched this at the thematic discussions of the Commission on Narcotic Drugs, and will fully launch this at the Commission on Narcotic Drugs. What you can see on screen is what we're envisaging for this initiative to do. So first, we would need to, based on what Adam has presented, develop evidence-based treatment protocols that have elements of behavioral interventions, but, and that's a novelty, also have elements of pharmacological treatment. And we hope that this can be implemented in specialized community-based programs in different settings in the world. And as a first step, we would need to see from the medications that Adam mentioned, which are already maybe for another reason available in what kind of settings. And obviously, we would like to hear from countries like as yours, who would be interested to join such an really novel initiative. So with that, we would then develop also a study to test the effectiveness and safety, as well as different implementation outcomes. And after a pilot, hopefully take it to a multi-country study so that we can learn about scalable interventions for treatment of stimulant use disorders in different countries and regions. What we learned, implemented, take it to an implementation package, and hope for country level adoption. So UNODC is really grateful for our informal research collaborative of researchers such as Adam, who are working for many years on both the development of medications and psychosocial interventions for different groups of people using stimulants, obviously with a focus here also on synthetic stimulants such as methamphetamines. And we are really ready. Please do reach out if you want to be part of the team that develops, designs, or later on implements and evaluates Scale Up. And yeah, we are ready also for any questions you may have. Thank you so much. I mean, this is really exciting for us, and we think there is really momentum right now. Thank you.